All right. So I'd like to welcome everyone who's here to our 2026 ARCA Virtual Learning Institute. We're concluding our second week of presentations. We have a few more weeks in the month of May that presentations will be held live. They're also available via video. If you're not able to make one of the live presentations, some CRC and CVE continuing ed is available for the recorded. Today's presentation, applying disability identity models in counseling practice. As we move through today's presentations, we ask that folks keep their mics off unless you have a question and you're asking the question. Questions can also be put in the chat. We'll do our best to monitor those and answer those as they come up. I would like to take a moment to thank our speakers, Dr. Lynn Pierce and Mr. Kaz Sortino. I keep wanting to say doctor. It's going to be in the next 2 years or so,
Future
so
doctor.
we'll get used to that. Uh, Dr. Pierce is an assistant professor and PhD coordinator at Mercer University. She has worked with clients and students with many disability presentations in higher education disability services and other rehabilitation-focused settings, in addition to career counseling and private practice. Dr. Pierce uses a disability culture and identity model that is trauma-informed and grounded in disability justice. As a disabled academic, her advocacy work focuses on normalization and recognition of disability identity
Right as the ESL interpreter, a deaf Sophie.
to support
Sorry.
cross-disability. All right. And Kaz Sortino is a LPC who did come to the University of South Carolina, but now is at Mercer University. He has been working for a number of years in both community mental health and private practice settings. Kaz has held identity in the disability space, having been diagnosed with CP. Kaz has experienced the impact of the lack of disability competence in the profession, both as a client and a professional. And I'd like to welcome you both and remind the presenters and attendees that this presentation is being recorded. And with that, I will turn it over to the presenters.
Thanks so much. I'm glad that the media starting early only stepped over my intro, not Kaz's. So we'll get that done in the first few slides and then it'll go away and it can't cause any more problems. As Christine said, we will be watching the chat. So if you've got questions, please feel free to shoot those our way. And we will get rolling. So learning objectives, we're going to be doing just a little bit on disability as a culture rather than a medical condition or impairment. I think given the audience, we can move through that sort of fast, but also helps a little bit with our positionality, which we will discuss in a second, and kind of how we're approaching this. So really understanding the grounding that we're working from. Explaining a couple of disability identity models that are relevant to counseling practice, and then really kind of linking that to how Kaz and I do this work with our clients and how we train students to do that work. And this presentation comes out of a lot of our conversations about really just what it means to be two counselors with held identity working in disability community, and how that work sometimes looks different maybe from what our colleagues are doing, and trying to bring some of that in to discuss it just a little more transparently with some good solid examples of lines of questioning and different kinds of interventions that you might be able to use. So I mentioned briefly positionality, and it's sort of in our bios. But just to be super transparent, I think both of us are very identity forward. I certainly align with, say, the word movement within community. I'm an ambulatory part-time wheelchair user and typically a service dog partner. I'm in between partners right now. And so all of that definitely alters how I come to this work. Kaz?
Similarly, held identity alters how I show up and come to this work, aligned with the Say the Word movement, aligned with grip culture. I think those things are important framings for how we're going to talk about this and how we show up to do this work.
Yeah, and we'll have to come back to it too, right? Because we have to broach and we've got to work on our own internalized stuff and how we might be different from clients in this space as well. And so I think just
For sure.
transparent conversations about that, right? This is a lot of the conversation Kaz and I have had, that these conversations happen behind closed doors often. And so trying to get some of those conversations a little bit more transparent and open. So we pulled the Brown quote about disability culture. I think a lot of the presenters in this lineup have used this quote in the past. I've seen this on other people's slide decks. I think it covers what we're talking about, right? That if you ask an anthropologist what a culture is, they're going to mention these things: art, music, literature, other expressions of our lives, some sort of shared history, maybe a shared struggle. And perhaps pride in that identity and culture, right? All of these elements are definitely there. And we had a little bit of a conversation when we grabbed this quote because I know it's on the older end. And this sum up, right? Most importantly, we are proud of ourselves as people with disabilities. We claim our disabilities with pride as part of our identity. We are who we are. We are people with disabilities. And there are a lot of sub-communities within disability community that would say the language doesn't align, right? That this is very person-first language. It is not identity-forward language, and that maybe even that's not super compatible with disability pride. And so there's kind of this ideological pluralism, right? And sometimes that extends to conflicting access needs. But certainly where we're all at looks just a little bit different. And so I just think that it's funny that this is one of the better quotes that we have to sum up what we're talking about when we're talking about disability culture. And even it maybe doesn't go quite as far as we would like. Kaz?
I agree 100%. I think that it is maybe the best quote that we have to encapsulate disability culture quickly and kind of understand quickly and conceptualize disability as a culture. And it doesn't align for me. I would have changed the language. I would have liked to see the language changed to a more disability pride, disability forward language set. And so I think, that kind of is to me, the crux of the issue is some of the best things that we have, some of the best tools and framings that we have are imperfect. And as we try to fill those gaps, it's a lot of work to do.
Right. And there's a history, right, of academic not looking the same as in community. And so our little example, and when you have the PowerPoints, it is embedded. I'm going to have to pull it over from another window. This is an example, though. It's just like 2 minutes of video. And it's something that I use in my classes when I'm talking about how this looks different when it is done in community, by community, for community, within that space. Versus maybe our more academic spaces. So I'm going to play it and then I'm going to give just a little bit of a debrief on it, and then we're going to move on into our models.
KQED logo animation, white letters on black background. Captions are available open and closed. Top right is the ASL interpreter, a deaf Southeast Asian woman. For more accessibility options, visit kqed.org/kinetic light. Together, 2 women in their wheelchairs, Alice, black, and Laurel, white, fly overhead. Alice.
Hi, welcome to If Cities Could Dance. We're Kinetic Light, and we've been working in the San Francisco Bay Area.
Jiran, a black man, dances on the beach and Ed Roberts campus.
We're here to share some of our perspectives on disability arts and our creative process.
Alice traces wires projected on a stage floor.
We are disabled artists making work that nobody else would make for us.
Dancing in barbed wire, Jiran turns to face Alice and Laurel, who embrace inverted in their wheelchairs.
Work that has implications for how we understand intersections of race, gender, disability, technology, design, access.
As Laurel bounces, Michael, a white man, watches intently.
The audience is the most important member of our troupe, and in particular, other disabled people. So when we present our work, it's a two-way conversation.
Jerron rises, his palsied arm rested on his chest.
Kinetic light, it's a beautiful intervention. And I love that we use that word because it signals that we might be obsolete in a decade. We might not be necessary. And we shouldn't.
If cities could dance.
Dr. Pierce, I think you're muted.
I figured it out. So I love just that brief example. And often I position it in my classes right after we discuss the challenges of representation in media, right? Because all of a sudden this is so different experientially from mainstream media. So things of note there, right? Open captioning that's super high contrast, also closed captions available, ASL that's embedded. Sometimes this is the first time my students have ever experienced audio description, especially by default. There's a link for additional accessibility needs, and that link includes transcripts, different versions of enhanced transcripts with and without time code, audio only versions. Also, Ed Roberts' campus is featured here, which is a universally designed building with a helical ramp. So everything is, no stairwells, no elevators to navigate between different floors. And there are a lot of other UD features. And so it's a great example. And then if we translate that over to what it would look like when we're co-creating spaces for counseling, we get a lot of the list that we all would love to see ideally, right? Intake paperwork in plain language format, in screen reader compatible formats, large print available by default, wayfinding support, other information about practice buildings in advance, like photo guides of parking and the ingress or egress that are available on websites, existing spaces for mobility devices, service dog partners in waiting rooms and in offices without having to move furniture, low scent policies, access check-ins being a norm, right? Just checking in with people about whether or not their access needs are being met when they come in, clear low barrier processes for requesting information, right? All of these pieces. And I'm gonna get off my soapbox because this would be its own like 3-hour workshop, and I've done that workshop. But what we also see is that it doesn't always map up, right? Because we know that there are widespread care gaps, and around half of adults are reporting issues accessing mental health services. And that's for a lot of different reasons, but the lack of physically accessible facilities is often on that list. I work in a major metropolitan area, and when I was finding my clinical site, it took a very long time because it was non-negotiable that that space needed to be physically accessible. And there were almost no places to choose from, right? So there's this gap between the ideal, the ethical, the moral ideal, and what actually is physically happening often. All right. Models.
Yeah, we want to look at a couple of models of disability identity development today. Particularly, we're looking at the Gibson model from 2006, which I recognize is on the older side of things, and yet it is one of the better examples that we have, which again kind of ties into the challenge, is that there's not a ton of folks doing this work. This is not something that is frequently and consistently revisited in our field. I don't know that I've seen anything that touches this model all that much or reimagines it or re-envisions it. And so as we look at these models and you go, these are kind of getting dated and they're maybe imperfect. Yeah, absolutely. And that's a thing we're going to circle back to as well. But the Gibson model of disability identity development has 3 stages. It has passive awareness, which is beginning to understand and conceptualize that you exist in the world differently. That things are maybe not going to operationalize the same for you, that disability is something that is impacting your existence really directly. The realization is coming to that conclusion full on, saying, okay, the world has ableist tendencies. There are going to be real and concrete challenges for me as a disabled person moving through the world. Um, and then you move towards acceptance. What does it look like? How can we manage this as we move forward, knowing that it is a part of my identity, is a part of my identity that I likely cannot change. And so I need to figure out what does it look like for me to come into this identity, step into this identity fully, understand it, accept it. Usually this acceptance stage includes becoming part of community, engaging in disability community, engaging in disability spaces, and going from there. Those are the three Gibson stages. That's what they look like. The other model we're going to look at is the Forber-Pratt model of social and psychosocial disability identity development. This uses statuses, not stages. Forber-Pratt feels very strongly that these are statuses and not stages, because in part they're not necessarily linear. I think that that's a big uh, reason why that language shift occurs. And they look a little different. We've got acceptance. Again, that's kind of the similar understanding of I hold a disability. What does that look like for me in the world? How is it going to impact my existence, impact the way that I operate and move in the space? And what does it look like for me to accept and kind of embrace that? And then you kind of develop your own relationship to it, right? You develop a relationship to your disability identity that allows you to accept, understand, increase your own awareness and your own knowledge. You move towards adoption, where you're usually, I think of the word embrace here. You tend to be moving towards the embracing of that identity and saying, okay, this is not necessarily a negative for me. It's a positive identity piece. It's something I feel okay about. It's something I have a strong relational tie to. And then you move towards engagement. And for Forber-Pratt, that is when you're stepping into community. That is when you're starting to do the what does it look like for me to be a part of the disability community? Where do I find my homes in this in these disabled spaces? Real quick, but I think important for the rest of what we're doing. Strengths of the models. Both researchers, or all researchers for both models, I guess, is better language, had held identity of disability. I think that that matters in the way that they shaped and formed these models of disability identity development, because I think you can see the held identity show up in the way that they move from kind of a moral model or a medical framework to a psychosocial framework that talks about accepting disability as a part of your identity and as a part of your culture and community that you're going to engage in the world with.
Yeah, and then I think one of the strengths, and this comes in with teaching maybe a little bit more too, is a lot of our students don't have the words, right? If our students aren't part of disability community, they don't even really have language to talk about disability often on the front end, right? And that can be a very uncomfortable process for the abled folks in the room. And so I think that the other piece is that these models give us as clinicians who maybe haven't had an experience of disability ourselves or haven't been near that experience before, some awareness of some of these processes and gives some words to communicate about those processes, both with one another as we're doing case consult and also potentially with clients. And we'll talk a little bit about how that might look as we get into the clinical component.
Yeah, I really do think that it helps with the conceptualization of language, especially if you have people with held disability identity that maybe are experiencing this in real time and don't have language for it. I know I did, and when I was living it and kind of going through it, it wasn't something that I had the ability to grasp language around. And so encountering somebody who had language to offer, should I have been seeking it, could have been hugely helpful.
Yeah. Limitations?
Yep.
Here's the bad news.
There is bad news. The models do not consider differences across disability adequately. There's a big difference between somebody who is late diagnosed disabled and somebody who is diagnosed disabled like me from birth. Those disability experiences could not be more different, and the models don't adequately account for that difference. They also don't account for difference across disability type. Um, Late diagnosis is different than acquired, which is different than from birth, and all of those things are, um, you know, physical disability like mine is different than other forms of disability that folks might have, and the models just aren't positioned well to kind of capture all of those differences.
And Kaz and I had some fascinating discussions about this as we were planning the presentation, and you're going to see it come up in which slides which of us take, because we work in different portions of community based on our own diagnostic journeys and experiences. Even though I think on the outside, a lot of people would look at us and put us in very similar categories, right? Both with some sort of physical and mobility based type of disability. Because I did get late diagnosis. And so as we get into some of the examples, that's a lot of the community that I'm working with. Congenital disability, but without answers or diagnosis, or diagnosis well after acquisition of a disability, one of the two. And it shows up very differently depending on what aids you're using, depending on what your medical experience has been, right? All of those different pieces really factor in, and none of those are really accounted for in any of the frameworks, actually, that we're aware of.
Sure. And the models of disability don't account for the impact of the medical system on identity development, which is huge, right? Your personal journey of going through the medical system and how you experience it as a disabled person impacts significantly the ways in which your disabled identity form, and the models just are not positioned at this time to account for that impact. And part of the reason why the models are not continuing to be positioned and repositioned is that the researchers for both of these models have left academia, which I think is just a huge portion of this problem. Academia is not an inherently accessible space, and if we continue to intentionally or otherwise, unintentionally or otherwise, chase disabled academics from uh, academic spaces, then these models don't get built on. And
Yeah, we've got a
so I think,
huge retention problem. We
yeah,
really, really do.
enormous.
And Kaz and I were talking about this too, where it's like, well, the fact that there's held identity with these researchers is so good, right? Because nothing about us without us is true. And also, so often, if there aren't disabled people in the spaces, it's just nothing at all. And so I
Sure.
think there's that constant friction, right? I know that there is some work being done with the models, right? There's some inventories that have come out in more recent years. But there are some big gaps here still in research that I think there's a struggle to fill, partially because of the retention problems that we have with disabled folks coming up into positions where they could do this kind of research.
Yeah, I think the balance is nothing about us without us is wonderful, and that is true, and I will hold to it until I leave this planet. But that doesn't mean that everything about us has to be by us. Occasionally, we're allowed to be included in things that other people are doing for us and
Especially people
about
with
us.
more leverage, access, whatever.
Yep.
Power.
Um, but not to lose a ton of time on that soapbox, which I will. The models are not widely taught, particularly outside of rehabilitation programs, leaving potential awareness gaps for clinicians. I don't think I've ever had a colleague who learned these models in class. Um, I'm in a PhD program right now, and I raised the question in class the first semester if anybody knew any of these, and they did not. These are not widely taught. Um, these are not widely presented as models of identity development in the way that some of the other models of identity development that are available for other populations are, and clinicians need this understanding. Um, they
And we
do
addressed
offer,
this a little bit with Forber Pratt, just this last point, right? There's this potential bias in these models. I think when they're not taught and they're not taught well, or they're not taught fully, or there's not full understanding, right? When there may be a footnote, even in a rehab class, like Kaz and I had to be like, oh, we didn't know that Gibson held identity within community until we started researching for this presentation. To me, that's a problem, right? And so when they're not really being fully addressed, you run the risk, because they are set up with these, 3 or 4 kind of keywords, that you can get that bias toward an outcome of kind of arriving at you
Yep.
know, that last identity development point, rather than this exploration and a nonlinear process that we are going to discuss.
Why is this clinically relevant? Disability identity is associated with higher self-esteem. When we allow people to move through the stages of disability identity development and move through the stages of kind of self-understanding and self-acceptance, I said stages, but we talked about the fact that they're not all stages. It is a nonlinear process. When we allow people to move through that nonlinear process and come to a place of self-understanding and self-acceptance, it has enormous impact on their self-esteem. Disability identity has also been shown to predict lower rates of anxiety and depression. And disability pride has been shown to be an effective way for disabled clients to protect their long-term self-esteem. So giving clients adequate space to explore, understand, and develop this disability identity is one of the kindest and most impactful foundations we can lay for their long-term mental health.
And I am still watching the chat for questions. And I know that we moved kind of quickly. So if we need to go back and pick anything up, do feel free to throw something in the chat. We did want to get, though, I think so often we have presentations that are very on the theory end, and it's like, okay, well, model this for me, right? Help me understand what I do when I'm sitting across from somebody. And so we wanted to make sure that we were spending some time on that. I think we've got a few caveats as we kind of shift to that, because we've got a little bit of time to kind of clear the air. One of those things is that most of what we're about to talk about handles those models that we just discussed in a kind of indirect manner. And that is intentional. We're going to pick up briefly, like how to work with this directly, but generally, I think we are both of the belief that you do that once you hear an invitation from a client, or if there's not kind of a clear invitation, if the client isn't initiating it, then you address this directly when there's really good clinical indication to do so, and then you do it only with good rapport and care and caution, because it can really backfire very quickly.
Yeah.
Kaz,
I
thoughts?
think I think really strongly the reason that we're not just saying, and here's how you present these models to a client, is because I think that if you do that in a way that is poorly timed in a client who is not ready, you're actually hoisting an identity that they're not prepared to receive onto them. And I think that that has the potential to do a good amount of harm. And so I think the reason that we kind of have these exploratory things, and it's not just like, here, apply this identity this way or this theory this way, is because part of it is creating a space for the exploration and a space that is safe enough for the client to come to their own conclusion on their own disabled identity in their own time.
And some of that's just because of the nature of disability, right? We talk about this often, that disability is a strange identity, in that anybody can join this group at any time. And we talked a lot already about some of the factors that are going to influence how somebody comes into this space or becomes aware of the fact that they have this identity. And so it's not like your typical developmental models, right? Where it's like, oh, well, ages 3 to 5, here are our tasks, right? This is very different, because people are coming to this in different ways and may continue to come to it again and again across a lifespan, and interact with disability identity and what that means for them and for their relationships and their spaces and their identity and their sense of self, as they acquire new conditions, as they get new information, as there are treatment changes, any number of things, right? And so this just is a little bit different. And so much of it is individual. And that means that so much of it needs to be exploratory. I also think that this kind of warrants a note about our clinical positionality. Both of us tend away from kind of CBT solution focused work with this population on the whole. And that's a bias of the two people presenting this that I think needs to be aired. Kaz?
Yeah, I think, you know, that is not to say that there are not CBT solution focused clinicians who are maybe doing a wonderful job with disabled clients. I'm sure that it's true. I'm sure that they're out there. Maybe they're in this room, and I'm really glad that you're here. To me, and from my personal kind of conceptualization and understanding, you can't solve your way or cognitively reframe your way out of disability. That's not how I would want it presented to me. And so I like to present it differently. And that doesn't mean that you're doing anything wrong or a bad job, but I would encourage you to think about, am I framing this as a thing to be solved? Because it's not that.
Yeah, and I work a lot with late diagnosed, long time to diagnosis, or misdiagnosed populations. And so a lot of them have had negative encounters with CBT, DBT due to those misdiagnoses. And so even when it's not, so much as of this is avoiding any sort of able bias, right? And so even when it's not ableist, it can land that way. And I'm very aware of that kind of additional sensitivity to that kind of structure, that kind of framing within that population. So there's kind of a global note on anti-ableist approach. Kaz, thoughts?
Yeah, there also just like a secondary thought is when we're framing things from that solution focused perspective, um, if that's what you're doing, be cognizant of what you're framing as needing the solution. Because so often what has been framed to me in clinical settings as needing the solution is the disability. And for me, that's not true. For most disabled folks, that's not true. There are societal structures and things that are causing the impact, and you can't reframe your way out of those. And so what ends up happening is it becomes kind of personalized, and the onus gets put on me professionally to figure out how to solve my disability within the world. And it should be the world that's solving its own ableism, not me solving my disability. And so just cognizant and careful of those frameworks.
Yeah, and I think in general, just making sure that we're continually cultivating, because this is an ongoing process of cultivating an anti-ableist approach and an affirming framework in our clinical work. And then I think part of that is language too, right? And so I think language is always the easy example in a way. Very complex, but easy. And this is an opportunity, right? Like you have an opportunity depending on where someone is coming in to model more affirming language, to empower someone's chosen language, right? And some of this is going to depend on the timing and on who's sitting across from you. And so I think all of those things are things to engage with, get immersed with, um, and to really just continue to explore, right? As you're continuing to build up who you're going to be as a clinician. And I see a question about the models in the chat around congenital disability versus acquired disability. And so I think we've kind of talked about this a little bit, right? But it's going to look different for everybody. And I think it's different flavors of all of the same problems. Kaz, we've talked a little bit about kind of like how the internalized ableism, just as an example, shows up differently. And
Yes.
we're only two people. We're not representative of everybody on the planet, but
I think for me, a couple of things that stand out um, is for me as a person with disability from birth, congenital disability, um, community was not my last stage, my last step. Community was my first stage, my first step before I understood my own disabled identity, before I understood any of those things. Just by nature of the spaces that I was in, the medical spaces, the educational spaces, the recreational spaces, I was surrounded by other disabled folks, often, nearly every day, especially in the summer, pretty much every day. And that formed and shaped my relationship to disability in a way that is concretely different than somebody who is late diagnosed or acquired, because they are coming to that relationship not as gently as I, as an individual, got to. And so I think it's going to be all the same stages. It's going to look dramatically different from my perspective into how those play. And I think more research is needed. Is the like true answer. More research is probably needed to look at the exact starkness of that difference, but my estimation is that it's pretty stark.
and I think we're going to get there with some examples too around kind of the diagnostic reframing work that I do a lot. So Kaz, why don't you take us briefly through some narrative rewriting examples, and then we'll do that
Sure.
as well.
I like narrative rewriting a lot as a clinical technique for disabled individuals. One of the things that it does is it places disability within a social, cultural, and a relational context. It allows disabled individuals to identify and reauthor narratives that may have been written for them. It assists in the formation of a positive disability identity, and when applied to diagnosis, can help clients reinterpret beliefs and messages given new information. When you are disabled, narratives can get formed for and about you without your consent an awful lot. Um, about what you're capable of, about your diagnosis, about your relationship to the world around you. And it's very easy, especially as a child, to just internalize some of those things. Adults told you they were true. Why would they not be true? Adults tell the truth, right? And so then you carry those things with you, not realizing the impact and the harm that they may be having on your ability to understand self and to operate. And getting space to explore and understand and rewrite those narratives that maybe have been decided for you can be incredibly critical in moving towards strong disability identity development. And so some narrative rewriting examples that I like: what does blank lead you to believe about yourself? You could insert a disability here. You could insert a specific symptom. There's a lot of things that you could choose to insert into that blank to just kind of prompt the exploration of like, what is the internalized narrative that maybe lives here? Start to get an understanding as a clinician of, okay, what are we operating with? What does this person understand themselves to be at this time, and how maybe can we reframe it? I also really like, if your disability had a voice, what would it say to you? I think as a clinician, you have a responsibility to be okay with whatever the answer is. This is a question where you might get an answer that makes you uncomfy. Because
It's one to just stay curious on.
Yep, absolutely stay curious. I would not give a friendly answer all the time, especially depending on the day and how my body is treating me and how I'm operating within the world. I might give you an answer to that question that is harsh and kind of dark, depending on the day. That's not wrong. That doesn't need to be reframed. It needs to be explored. That's my relation to it in the moment, and that's important for you to stay curious about as a clinician. Identify a story you tell yourself repeatedly. Now write about 3 specific moments that contradict that story. Um, This can be particularly helpful in reframing narratives that have been written for us. Things maybe parents or doctors or somebody else have said, physical therapists, whoever, what have you, have said that maybe we need to do some exploration on. And the one I like maybe most is whose is that? Because the thing I've been learning both with my clients and myself um, is sometimes I will say things out loud because they have a lifetime of truth behind them from other people. And then I will clock, I don't believe that. That thing I
And
just said is not mine.
this or some version of this is the main one that Kaz and I both agreed we both use all the time, even though we do slightly different work.
All the time. All the time, constantly, really regularly, whose is that?
Whose
Because it
story
prompts the
is that?
question of, is that belief yours? And maybe it is. They may come back to you and say, yeah, I believe that, which prompts its own exploration and discussion and kind of creates a new avenue. But there's also a real chance they come back to you and go, oh, that's my mom, or that's a doctor, or that's a kid from school. And then they realize, it allows the realization that, oh, I've been holding this and it's not even mine, which invites a rewrite, which invites an opportunity to do some really positive work on identity development.
Yeah, and there are some different ways to get at that one too. We're going to move to diagnostic narratives. I've often got folks who had a lot of kind of bad information, especially very early, at really pivotal stages. And so often if I'm having trouble getting at it, I'll also, I'll hear a really, really strong negative core belief coming through. And I want to be asking something like, when you hear that, whose voice is it? Right? And sometimes that gets the pause, right? Because they're like, oh, that's my mom's voice in my head, right? Whatever it is, whoever the person who didn't quite get it or didn't quite give the support, perhaps, is who they're going to hear that with. So, I work a lot with late diagnosis and long time to diagnosis and just kind of really difficult diagnostic journey populations. So I threw down a few sample props. I'm doing a lot of diagnostic narrative work, more maybe than kind of the narrative rewriting work. It's similar. It's its own little subcategory, right? I think all of this is narrative rewriting, and not necessarily all narrative rewriting is around diagnostic narratives. So often I'm exploring this time period where people didn't have clear answers. And so that often increases those like wrong answers, right? And so I often use myself as an example with my students. It took until I was 27 to be diagnosed with a congenital condition that probably could have been diagnosed when I was about 10, is when I have a lot of diagnostic narrative examples that started showing up in my life. And so that's a long period of time to be encountering barriers without clear answers. And I was also experiencing some medical neglect where I was never going to get those answers as a child, right? And so there were a lot of other people trying to answer the question of why are you having these problems for me? And they basically boiled down to lazy, crazy, stupid, whatever, right? Fill in whatever negative modifier you want here. And this is not an uncommon kind of phenomenon. And so then once people get diagnostic answers, at least with the population that I work with, I often find that there is kind of immediate relief and then maybe a lot of anger and a lot of grief around what could have been had I known sooner. And then there's also a lot of these hung up things where it's like, well, I've got this story. Well, why did you quit doing that sport? Oh, well, I wasn't strong enough. Okay, well, whose is that? One, right? And then two, talk to me about what was happening at that time. And does it map up with what we know about the diagnosis that we now have as new information? And so it's a lot of going back with this new diagnosis and reworking things. Sometimes that is, specific interventions, even interventions that have failed. I do work with a lot of people who have been told, I work a lot with dysautonomic populations. And so a lot of them have experienced people trying to get them to CBT their way out of tachycardia for their entire life because they didn't know that it was tachycardia. And CBT works really well on anxiety in certain situations, but not so great if you're tachycardic. And so then doing CBT around the anxiety associated with the tachycardia, once you learn to differentiate what is actually biological, is like where a light bulb goes off, right? And so sometimes it's other kinds of interventions, but often it's talking these things through. Tell me about a time when this thing that we're exploring was true for you, and getting that story and hearing that story, mapping that to their timeline, because we're going to get into some meaning making as well here in a sec. You're seeing this thing, whatever the thing is, differently now that we know about the diagnosis. Where else did that show up for you, right? What explanations were offered for you about your experiences over time? How did other people respond to you about your needs? I really love telling me about a time you felt believed or disbelieved, because that also gets me into some of the social connections that we'll hit on briefly. And I do a lot of relational work as well. What's changed as you have a language for this experience? Right. And sometimes there's a lot of relief associated with just being able to name and explain it to others. There may be an increase in support. There may be fear about some of the names that came up for some of these things. And then what parts of your experience still feel unnamed is also one that I really love, because it gets at any remaining gaps. And especially with really medically complex populations, that one's important. What did we miss basically becomes what part of this experience still is unnamed or unexplained.
Just a quick tag on diagnostic narrative. Don't rule out the need for diagnostic narrative work just because somebody has a congenital disability. As a tangible example, I've always known I had cerebral palsy, but when I was about 18, I fell really, really hard and messed up my back pretty badly. Um, it took me a decade to get that effectively diagnosed because I could not stop getting physicians to write it off as you have cerebral palsy. And so there can be diagnostic narratives that need to be explored, even as somebody has kind of a strong disability understanding and disability identity because of a congenital disability. So just, that can come up even in places where you might not expect it, I guess is a thought.
Yeah. And we've got a few approaches left. And I think the caveat here is that all of these get even more and more individualized and personal. So we're going to go kind of broad strokes and give examples where we can on some of the remainder.
I think allowing for meaning making is really, really important in the formation of disability identity. So often, um, the meaning of disability has kind of been presented to folks, and here's what it means about you, here's what it says about you, and they've not been given a ton of space to come to their own understanding and their own relationship to that, and kind of develop what it means for them. Um, and so interpreting experiences, understanding the personal and broader significance of life events, integrating experiences, incorporating these interpretations into one's life narrative to create a coherent sense of self, and then finding purpose. And I think this is again one of the times where we have to be okay with whatever the answer is as a clinician. Sometimes, as people who want to help and want to be incredibly incredible problem solvers and incredible helpers, we think that finding purpose might look a certain way, that finding meaning might look a certain way. Um, but especially in disabled community, finding meaning and finding purpose can look a lot of ways. And it's not for us to decide whether that is an acceptable sense of self and sense of purpose. Um, it really isn't. And we can kind of fall into that trapping sometimes of saying, well, don't you want more? It's okay if they don't. If they are well suited and well situated and happy in the meaning that they're finding and the thing that they're pushing for in this meaning making process, that's great. You did your job. Don't undo it by pushing too hard too far.
Absolutely. And then I just threw some other areas in which I work or where I train students because I do have rehabilitation practicum students pretty frequently now. And so I'm having to build up my my how do I teach people to do this thing that has become kind of second nature for me. So I threw a bunch of them on this slide. I'm pretty much always starting with community connections and collective identity development if they are open to disability identity at all. And that's for a couple of reasons. One, sometimes it is the aha light bulb moment, right? You're going to know exactly what age this human is because of the Harry Potter reference. But I was giving a guest lecture on disability once, and I got, I don't know, 20 minutes in or so, and one of the students unmuted and said, I think this is my you're a wizard Harry moment because like I never thought of myself as having a disability." Right. And so there can be this kind of light bulb aha moment. If people are open to it, the really exciting part of this is that you're no longer doing the work on your own, right? Because getting them connected with community is how you get more, there's kind of nuts and bolts things here, right? So I try to connect to broad disability community and then also to whatever sub-communities I can identify. So if there's a particular diagnosis or category of diagnoses in play, there are probably resources on Facebook closed forums, on Inspire boards, on Reddit, on whatever the website for that disorder is, right? There's going to be doctors lists, possibly curated by other people with the condition. There's going to be information about any new to your client diagnoses. There's going to be hacks from community on things that work that doctors aren't necessarily going to tell you right off the bat. And there's going to be solidarity, right? And a sense of connection, which particularly as we get into some of the relational and grief and loss, which can be connected, may be really important. It may be really, really important to increase social supports at a time where it is possible that they could be decreasing and that somebody is becoming more isolated for a variety of reasons. So that community connection piece, relational and ecological and systems kind of work. So some of this comes out of the narrative stuff, right? That whose is this gets me a lot to work with often. But I also do a lot of kind of systems and ecological stuff. I do social atoms where people map like how close to them are different people and things and spaces in their life. Literally sometimes with a sticky note or something. And so often then I'll ask them, how would you want it to be? And I see how those things move, right? Who is far away, who they wish was closer, and what does that mean? And is it connected? And then the opposite as well. figuring out how supportive different people and systems and spaces are is going to be really important. So that's helpful work. Grief and loss kind of stuff. And here it can be very, very different. This can get super ableist super fast. I tend to like what has changed about the way that you imagine your future. And I tend to like what losses feel acknowledged and which feel invisible. So things more along those lines, right? Where I'm kind of sussing out deeper meaning behind those things. And then embodiment stuff. So like, what is your relationship with your body right now? What accommodations and supports help you feel more like yourself rather than less? And then I really love exploring what does safety or trust in your body look like? That's one of my favorite ones and one that I come back to a lot because basically no matter what we're working with too, that's going to really, really improve client outcomes if we can find ways to make them feel and their nervous system feel safe, right? That's going to improve all of the work that we do. For me, that piece of how do we find ways and spaces and supports in office and out of office where you are able to improve the safety and trust between you and your body is sort of like stabilization work when we're doing trauma work for me. Because if you feel unsafe in your body and your nervous system and whatever other systems are impacted, it's going to be really, really hard to do any other work. And then we also can directly address disability identity integration. And I'm always looking for the invitation first, because if we're doing all of this other kind of exploratory work and we're staying curious and we're helping our client be curious about this process and what it means for them, they're probably going to get there on their own. And that invitation is going to become really clear.
I agree with all of that. I think a couple thoughts. One, I love somatic and I love body relationship work. I also think just being cognizant of choosing the right day, right? If I'm clearly having a nightmare of a physical day and your whole deal is like, let's get you present in your body. I'm already present in my body and I'm miserable. Let's maybe try something else today. And so a little bit of it is going to be reading the room and understanding the client and understanding, okay, right now this is what they're telling me, and maybe these are the things that do and don't fit based off of that. And then the other thought is, be open to the invitation being something other than, and let's talk about my disability now. It could be me for the first time coming in the room and going, oh, my back really hurts today. I'm pretty uncomfortable. Acknowledging that discomfort is me telling you something that I don't tell everybody. That's not a conversation that I have with everybody. And so now I've invited you into this space. I've invited an opportunity for discussion, and it wasn't, hey, I've got cerebral palsy, let's dive into that. And so be open to the idea that the invitations to broach could look indirect, but still be pretty clear. Why does it matter? Ooh, sorry.
Nope,
You want to
go
go?
for it, Kaz. I was going to ask you why it matters.
Oh, it matters a lot. There are not enough disabled clinical practitioners to treat all the disabled clients, which means we need help. We need folks who are disability informed and anti-ableist to be practicing, because some research indicates that only around 3% of practitioners identify as disabled. 3% is so low. And so we need folks adopting disability informed, disability affirming approaches to meet the need flat out. Disability is a culture, and understanding how identity develops is similar how we work with other marginalized populations. We have moved in positive directions, directions that still need pushing, but positive directions with several other identities, and that's wonderful. We take the time to consider how they're systemically impacted and societally impacted and how that impacts development. We should be doing the same with disability as often as we can. And then it is the responsibility of clinicians to ensure that they are understanding the cultures they are working with and engaging in a culturally competent manner. Disability is a culture, and so being culturally competent is 100% the responsibility of the clinician sitting across from the client.
And I think that means that we've got a few minutes for any questions that we didn't pick up in the chat or anything anybody has that they would like us to address. We could keep talking about this for hours, but
We
maybe
also
some
want to
other
respect.
time. As we're waiting for any questions to come in, Kaz, one takeaway that you would want people to have in just these last few minutes?
Yeah, I think the biggest thing for me as a takeaway would be, you know, understanding the models of disability identity development is important, but understanding how to create spaces for people to move through that process is more important. Understanding the stages and the those types of things is critical, but understanding how to create spaces for that movement is maybe the most important thing.
Yeah, I'd say that it's a process, and training folks on this. I think there's this real human impulse to want to have arrived at the place where we understand, and I think that we all know at least one person who was trained like 30 years ago and still has some holdover thing that they have held on to for like 30 years. For me, it's always the people who kneel in front of my wheelchair. I'm like, that's uncomfortable for you, for me, for everyone around me, right? We don't do that anymore, right? And so I think it's that piece, right? I think it's staying completely curious, uh, and not making it into a moral thing, right? Whether we're right all the time, because they think that that prevents the natural process that we all go through as clinicians too, where hopefully we're learning from each other and from our clients and from disabled clinicians and disability community to just do better. There's always better that we can do. Us too. I got to broach with my clients all the time. I
For
got to
sure.
check my internalized ableism all the time. So.
For sure. Absolutely. None of that is to say that we're perfect. We're working on it too.
Indeed. Any questions from our participants today?
I didn't see any that we missed.
Well, the one thing that really strikes me and I appreciated was the integration of that narrative, because there's no assuming that comes from the narrative, and it's all about that respectful curiosity. And I think you really brought that out in those techniques, how to incorporate that, in the um, exploration, with your client. So I appreciated that, and I'm thinking there's a couple things for folks' toolboxes, for when we go back to the office.
It's also so much more fun. It's so much more fun for me to hear somebody's authentic story that maybe they get excited about or emotional about, right? Than it is for me to keep taking a sud. It's so much more fun.
What were you thinking? How did that make you feel? And what is that behavior?
How doable does that change seem? 1 to 10. I mean, I'm MI trained. I'm not knocking it. I know that Dr. Walsh did a great job. And there's this piece, right, where I really do want to get to know my clients in this way. And this provides a really respectful way, I think, to do that.
Yeah, appreciate it. Well, I'd like to say thank you to both of our presenters today. So great to see you. Wish we were in person, but wonderful to connect no matter how, whether it's sitting next to each other or connecting virtually. And I'd like to say thank you to all our participants for coming today. We will continue with great programming next week, and so hope to see you all at the next presentation. Take care. Have a
Thanks so
wonderful
much.
weekend. And Vicki, you can